All right, thank you for staying with Daybreak. We're talking about the universal health coverage and also cancer care as well. It's been a bit of an issue in the country. The mortality rate is quite high, but also UHC has been rolled out in all the 47 counties. About 6 of them have launched it, about 41 still yet to go. But we're still talking about the tenets of it all: affordability, accessibility and quality of healthcare. Now we're talking on the issue of affordability. And Professor Olive, you're coming in this conversation. How do we ensure that healthcare is affordable to the people?
Thank you, Trevor. What we have seen in the hospital is that 80% of the patients coming are coming under NHIF. 80%. The others are coming under either paying cash or through the private insurance.
Yeah.
So you can see if we can really improve the NHIF, that is where the majority of Kenyans are. And what, in my opinion, needs to be done, we need to make sure that all the services are covered, and not just covered, but covered adequately. We are finding situations whereby, Trevor, you come, maybe you need radiotherapy, but the amount covered is like, if you need 20 sessions, maybe after 10 sessions, you know, then you are not able to go on. Now, that is not helping a lot, because then it means the disease is not cured, or, you know, then the disease will progress. Yeah. So I think we need to look at all those services, make sure they are comprehensively covered. I've seen cases where people come for chemo, and then after several sessions of chemo, they can't continue, and they can't afford. Yeah. So we need to make sure that, just for it to be comprehensive, make sure the treatment is complete, and then make sure that the patients don't have to add. Again, something else that is happening, which we need to, maybe as a ministry, we need to look at. Yeah. You are prescribed medicine. Then you find that for your limit, you can only get half of that medicine. So they come and tell us, you know, this is a prescription, but NHIF is covering maybe 80% of it. Yeah. I don't have 20% to add. And then what does that, you know, do to the patient and the recovery and the outcomes? So we need to look at all these services, make sure they are properly covered and comprehensively covered. Yeah.
So that's a big deal that Lenai will talk about. But Prof, how are you dealing with it in the UK? I keep insisting on this because I know most of the time the UK has a very different system, like you mentioned. But how are you ensuring that this is affordable to the masses?
Well, the first principle of the National Health Service is it's free at the point of use. Yeah. So we don't have a system of co-payment. I think it's probably fair to say that globally, and this is where I think in our partnership it's quite useful when we talk about benchmarking, what's the best way of ensuring affordability? And there are multiple different systems of how you pay for healthcare around the world. Some are entirely free at the point of use, like in the UK, but it still needs to be paid for. It's paid for by the taxpayer. So there are two questions of affordability. One is affordability for the patient when they present or when they need treatment, and then one is affordability for the economy. Yeah. And clearly the two are linked, because healthcare and high quality healthcare isn't cheap. So it has to be paid for at some point. Yeah. In Europe, it's a mixture of, if you like, public provision and an insurance system. And in the US, it's predominantly driven by an insurance system. I think in all of these concepts of affordability, I think the one thing that we need to move away from is, and you see this quite often in the US, you can be one medical bill away from bankruptcy. Yeah. So I think there are those overwhelming one-off costs that it's really critical to afford as a first step, and UHC, I mean, the details of that I'll leave to the experts, will address that. What I would say, and part of how we're working together in partnership in terms of affordability, one is that, to get back to the point of prevention and early detection, not only is it better for the patients, it's also possible to cure, and it's cheaper. Mm-hmm. So there is no doubt that is what all health systems are looking to do. Now, that's not easy, because it requires a well-trained health workforce, it requires access, as we spoke about. So this networking model is really important, because you want to get out to the patients when they have early disease before they present at hospital and need radiotherapy or, you know, whatever else of these fantastic facilities that Professor Magenda's hospital provides for the whole nation. And the other thing I'd say about affordability is we need to make sure the treatments we're giving are effective. Do they work? That's about the international benchmarking. Are the treatments that we give to a predominantly white population, for example, in the UK or the US, do they work in a Kenyan population?
Yeah.
So there's a lot of really important research that we're doing in partnership to address that question.
Yeah.
Because if you're giving an expensive drug and it doesn't work, then that's money wasted and it doesn't work.
Yeah.
So it's not good for patient outcomes. So there's clearly then a further issue about the cost of drugs, for example, particularly for cancer, can be very expensive. That's an entirely different issue. But I guess my summary position is there has to be payment for it somewhere.
Yeah.
And probably a mixture of some co-payments with support for the very poorest in society, effective use of the private sector as well.
Yeah.
It sounds like that's exactly what UHC is trying to do with that mixed model. But as I said, because there are multiple different models around the world, there is no one magical answer for this.
Yeah.
And I think very important first steps of UHC being rolled out. It may need to be adapted as you find out that some things don't work as well as others do.
Okay.
And again, that's what we're here to try and sort of provide support around, so that the best access for everyone in Kenya.
All right. Let me bring in Professor Kibwana back on this. And before we get into the issue of accessibility, because accessibility is not just about the brick and mortar, right? There's also the people who work there, and that has always been the biggest challenge. Would we really address this if we just stuck to the Abuja Declaration where we said we'd do 15% of our national budget to healthcare?
I think that's a very important a point because even nationally one can say there is underfunding of the health sector because currently we are spending like 2.7 US billion shillings on this sector, which is about 10% of government spending. And so if we go to the 15%, it means that some of these issues that we are addressing about the brick and mortar, about the staff, about the equipment, about the drugs, all those issues will be significantly taken care of. And of course, health is basically a county function. And so one has also to look at how does money from the national level in terms of Afya House, how does it percolate to the counties so that there can be spending there to ease the disease burden. So definitely, that is one important thing to be done to make sure that there is more money, coming to the county level, so that we can really convince our citizens that whether it is the staff, whether it is the facilities and all that, it equals what will be provided for at the private hospital level. And just permit me very quickly to say, for us, when we were starting universal healthcare in our county, in a subnational government, the package was for everything that we offered. Whether you are going to be operated, whether it's even chemotherapy, cancer treatment, working with the First Ladies Initiative and the ICI, Roche, SCF, working with all those. We made sure that people could actually be treated for very, very, very little. And even during COVID, because we had a COVID center, we were actually able to treat people for the 500 shillings then. And maybe because we had started it that way and we couldn't change it midstream, we still went through helping people when they had paid very, very little, although it also became apparent that there is a lot of burden on the county budget. But the point I'm trying to make is you can have a good package, you can provide most of these services, and it can be cheap. It doesn't have to be very expensive as such. It is affordable.
Yeah.
And the accessibility is, especially when the facilities are better and better, and because more money is committed to them. And if we go to the 35% for devolved funds, that definitely will give headroom for particularly improving the health, because when you improve the health, you improve the economy. People are better, they work better, and the economy expands, and you bring the money to the health sector. So one has to look at that big sum which is dedicated to the health sector.
Okay. Dr. Linai, there are some issues that were raised by Professor Mugenda on NHIF when some money, it doesn't cover all the therapy sessions, the chemotherapy sessions that people require. Sometimes it covers only 80% of the drugs that you need and you can't afford the other 20% and it's a full dose. How do you address those issues? And also as you address that, should there be a policy shift whereby doctors who are in government institutions are not allowed to have private facilities? Because we've seen situations where you go to a doctor and even though you might access some of the medicine there, they'll refer you to a private facility as well because it's also a money-making venture. So let's start with the NHIF one, then come to the doctor.
Thank you, Trevor. I think what needs to be clear is when we are told to choose the facility for NHIF, I think people need to know it's not just a matter of choosing maybe the one which is near you or so. They need to know the facility that is near me, what kind of cover are they having? Is it a comprehensive cover or is the one that we need to cost share? I think that is where we need to start. So wherever what we call the national scheme are choosing NHIF, they need to have that behind their mind. Because there are two types of cover, or three types of cover in NHIF. There is the one that you need to cost share. There is the one which is comprehensive, you don't have to pay anything. And usually their capitation or what they get from NHIF is a bit higher. Yeah. So we need to be aware of that. So it's not just a matter of just choosing a facility. So they need to ask, what type of cover of NHIF do you as a facility have? If it is comprehensive, let's go for that. If it is not, then they need to rethink about that. Yeah. Now, we have given leeway for those types because there are those facilities which prefer maybe that kind of cost sharing. So I think the first point is point of choosing NHIF. Mm-hmm. Now, in addition, again, of course, why are we cost sharing? Why are we having cost sharing? Of course, no. There are those who can be able to afford to pay something. And as I said, we have started looking at the issues of those who cannot be able to pay, what we are calling the indigent. We are already paying for them so that even when they go to the facilities or any facility, they are covered for. Their data is already there. Yeah. They are covered for comprehensively. So in terms of the issue of looking at the schemes, I think that needs to be very, very clear that there is the national scheme and the civil servants. Now, what have we done for the national scheme? Of course, earlier on, there were things like dental and optics that were not there. But in the new NHIF reforms, we have introduced issues of dental and optics to be covered for everyone, especially the national scheme. The national scheme is these other non-civil servants. Yeah. So that is being covered. What about for civil servants? What you realize is that there are two groups of civil servants. Yeah. There is the national civil servants, and there are those who are in the county staff. Now, for the national civil servants, they have already entrenched or taken care of what we are calling the comprehensive cover. Now, for the counties, it's between NHIF and the counties to agree on how to cover the people. The staff of the counties. Now, some counties have gone to that level of taking the managed scheme, which is a comprehensive cover for their staff. But you find also some counties, what they are doing, they are having a hybrid, whereby they are taking both the NHIF, the normal one, and apart from that, also looking for a private cover. But what we are urging the counties is they consider this comprehensive package for NHIF, which is taking care of everything, including even coming to the hospital of Professor Mugenda, will be taken care of. Okay. Now, on the issue of private facilities and doctors in public, this is an issue which has been on discussion for quite some time, but it's unethical, especially in the practice. I am a doctor myself, whereby when you see a patient and you deliberately prescribe and deliberately make sure that services which are within the facility of a government, you are making sure that they are going to seek them outside there. To me, that is unethical. It should not be done. And surely it should not be entertained.
Yeah. So this becomes entirely a moral issue, Dr. Lenai, because now the problem is, as a patient, and the doctors have a very interesting handwriting, they write things that you can't even read. So I wouldn't even know whether that medicine is actually there or not. I mean, I'm at his mercy. He says I have to go to a private facility out there. That's exactly what I'll do, because I can't question. I can't tell him that I know this drug is with you here. I wouldn't know. So how do we help the patients?
What you realize is that, as I said earlier on, it starts with the individual. I think the issue of being ethical is very, very key. And in our medical practice and the Hippocratic Oath, I think we are clear that at the end of the day, the life of the patient becomes priority. But all that is prescribed or you are sent out, is it true or false? We cannot be able to say.
But why don't we have a policy then that if you're in the public sector, just stay in the public sector? If you're private sector, in the private sector. For example, I can't be anchoring here and then in the evening you see me in another TV station.
I think that's a matter to be considered. That should be looked into.
Professor Oliver, how do you think we should handle this issue exactly?
I think I fully agree with you, Trevor. I know it's not an easy topic to talk about, but I think eventually that is what needs to happen.
Yeah.
You know, if you're in the public sector, be in the private public sector, because we have seen where you're in the public. In a public hospital like ours, you're being paid, but then you're also working for other private institutions. And of course, we are denying Kenyans the service. So I think that's a policy issue. And I think the government can come up with a very firm policy so that does not happen. The other one is a policy on the drugs, as you said. It's a question of also us coming up with policy. If you are coming to a hospital, for example, there's a policy that you buy the drugs from there. And everybody knows and is enforced. So I think those are some of the things we need to do. But coming back, Trevor, to the question of access, I think the question of the training is important. And I think we need to have a policy where doctors are trained en masse. We are finding, if you look at the oncology, there are very few oncology doctors. So what can we do as the central government and county governments to make sure maybe the next 5 years we have a plan where we are saying we are going to train and have like 500 oncologists, in Kenya, because now we are sharing the few who are there, and the patients are really suffering. So I think we need a policy, and I'm sure the ministry is thinking about it. I heard about it yesterday from CS, where he was saying we need a program. That airlift that was there some time back. Something like that, where we say we are going to have 1,000 oncologists, 1,000 renal specialists, and then we say maybe the next 5 years we are going to have all these people. Because then if they are available, then there's success. Yes.
Professor Graham, you keep making a very solid point, especially when it comes to cancer prevention, early detection. But how exactly do we do this? How can you prevent it? And how do you detect it early? Because most of the times it doesn't even, you're asymptomatic until probably very late. So does this mean that we just go for regular checkups? How do we ensure this works?
No, that's the $100,000 question. That's a great question. And again, every healthcare system in the world is struggling with this. I think I'll start with prevention. And it's not just for cancer, it's for any disease. It could be for mental health, it could be for cardiovascular disease. Any time we can prevent a disease, obviously, it's obvious that's good, because then you don't get the disease. And any time you can diagnose earlier, you first of all prevent long-term suffering, but also if you intervene at that stage, you can cure the disease. So you're then not just into the issue of managing chronic symptoms. Prevention is clearly predominantly a public health message. So, and we've seen this in the UK and in the US, smoking cessation, maintaining, good sort of, not too high levels of obesity, a sedentary lifestyle, so lots of exercise, healthy eating, a good balanced diet. These are all, public health messages for around the world that are equally applicable to Kenya. Early detection, essentially is what you're talking about is two main things. One is a screening program, and in the UK and in other countries around the world, we've had screening programs for cervical cancer, breast cancer, and I know actually we're working with the team in Kenya about a sort of breast cancer one-stop shop. What does that screening look like? And essentially that's about looking at sort of a policy framework about, do you have population level screening? Now these things are difficult and they can be quite expensive, but actually over the medium term and the long term they can be cost effective. And then the next stage, if you like, of early detection, when people have minor symptoms, we need to do an early test. So the example I'll give is around, again, esophageal cancer, throat cancer. If people have some difficulty swallowing, or some symptoms of that, how do we get out to them, do a test, have a look at the cells in the lining of the throat and see if there's any cancerous changes then, and treat them at that stage when we can cure them. So I think, back to Professor McGenda's point, we need to train a workforce that can deliver that type of care, to get out into the community, to prevent them to come into hospital with often late stages disease, or get referred into the integrated molecular imaging centre, these very sophisticated testing where you can detect cancer at an early stage before you could see it as a lump or on an X-ray, and then you can treat it then. So this is essentially around the matching of the infrastructure you have, the community delivery of care, and the public health message. So it's a holistic package about how you deliver this. So it's essentially a health service transformation that we're starting on here. Do we then need special centres for this? Because for me to walk into Olive Mugenda's KU, I have to be referred there. And by the time I'm referred, it means I already have symptoms. Well, so I think one of the things is around the devolution of healthcare. So, and I think this is where Kenya is actually a lot more advanced than the UK. You know, you've devolved healthcare budgets to the counties, so there's a certain level of access that needs to be provided within the counties, and then you need to decide to the national level what. For the very, very expensive tests, do you need that at a national level? And obviously, you know, that's where the referral hospitals come in. In the UK, and particularly in Manchester, you work around a network plan where we have this very successful cancer hospital, Christie Hospital, but actually because we're networked with data linkages, we provide that service at every hospital around Greater Manchester, and you get the same standard of care. And therefore, when you get detected early on, you can be referred to the most appropriate centre for early detection. And it may be a molecular scan, it may be some histology, it may be let's have a good look at the lining of the cells of your throat or under a slide to see if there's cancer there. And I think that's the other piece of transformation we haven't really spoken about, is the use of how we use the data infrastructure of Kenya to link in patients to centres of excellence to ensure early referral or early diagnosis. And I think, you know, one of the pieces of the infrastructure that Kenya has, and it's better than the UK, is your 5G data access and the sort of fibre optic cables that have been laid. So many of the foundations to do this are already there. So that's what I think is very, very exciting. I think the possibility to do this at scale for a large population is in place. All right. Professor Kibwana, let me bring you in on the third pillar here, and is the quality of the healthcare we're talking about. There was a time when there was a Ministry of Health gave medical equipment scheme to different counties to ensure that at least the quality was at par. But that didn't really work out. So how do we then ensure that this level quality access for everyone in different places?
I think that particular system of the medical equipment, I think part of the problem was there wasn't a good conversation between the counties and the national level so that they would be prepared for the equipment, they would have the staff, they would have, the place to put it and all that. So there was a bit of issues there, and even how procurement would have been done. Is it both of them, or was it the national level? And of course, given that the health function is county-based, I think that is why there wasn't a good conversation, good dialogue between both levels of government. But having said that, it's important that there should be common standards established, because part of what the national government does in our constitutional framework is to establish a common standards, and given the medical board and so on, this is something that is positive. But I must say, the health function since devolution, it has grown through leaps and bounds in terms of the facilities, the staff, the equipment, and all that. And therefore, we should work together to make it, to make it better and better. And let me just say a few things that were colleagues did indicate. Like the public hospitals, if leaders went into them and instead of always going to the private place, there would be more confidence, even with the citizens, so that they don't also keep on going to the private facilities when some of the public facilities are actually better, especially in rural settings. And I don't like this idea of, you know, you have a level of services offered for the very poor, another one for national civil servants, another one for county civil servants. I think we need to go to the point where the services offered you know, are the same, because Article 43 says every person has the right to the highest attainable standard of health, including the poor, our poor. And the NHIF has to really make sure that the services that they offer, like if it's a reimbursement and so on, that is done, you know, quickly, so that therefore that money can be plowed into making the services better. And there was a point made about mental health. I think in terms of the package, that is one area where even the private insurances, they don't emphasize, and it's an epidemic. So that is something that we need to include. And finally, the choice of facility. When you choose one facility and the NHIF, you kind of get stuck to that, and you have to be referred to go to another one. But if you have chosen a place and then you get sick when you are far away, then it becomes problematic. So even policy should consider easing that, so that you know, if, for example, there are 7,366 facilities that NHIF has approved, there's more flexibility, and you don't have to get stuck in just one place. And I think that would be good for customers of NHIF.
Okay. Dr. Linai, what is the problem with allowing the flexibility? Is it because then it opens the floodgates for corruption? Because there's also been a bit of concern that sometimes people are charged for services they didn't even ask for, because the patient doesn't go line by line. So that when I go to a facility, maybe private or public, the things I'm treated for is just one, but then NHIF is billed for more than 6 or 7 things that I didn't even get access to.
Let's start with the NHIF part itself. I think the new reform that is also coming around is that with some counties, how they are agreeing is if you choose, if you register for NHIF within the county, you can be able to access services in any facility within the county. And apart from that, even you can be able to be referred from a lower level up to the higher level without even paying anything. So that NHIF is already taking care of that, regionalizing and agreeing upon with the counties. That is already happening in some counties. So even with the new reforms, they are looking at how do you choose for a region, and so not just for a particular maybe facility. So that is already coming in. And as I said earlier on, yes, I hear Prof is saying that it should be cross-cutting for all the counties. But you find that some counties are preferring having both the NHIF the old way and also having a private. I think that's a conversation that the COG should be able to pick up and agree upon, that NHIF is the way to go, and we make it cross-cutting to across. So, and also agree that we are not bringing maybe any other insurance on board. What that insurance can be able to offer, why not make NHIF to offer all that? And that's why we are saying there is already a comprehensive package, or what we are calling the managed scheme. Few counties have already signed contracts with NHIF on such an arrangement. So we are encouraging counties also to go that direction. Now, on the issue of maybe you are tested one test, then maybe in the bill, NHIF is billed more tests. I think with the new reforms, one of them being the issue of biometrics. Yeah. You know, earlier on, people were using card, and that card could be used by anyone. One of the reform we have done is introducing biometrics in NHIF. And what you find is that for biometrics, you need your finger in order for you to access services. Yeah. So you need to be there physically. And even in this biometric, they can discern, is it the child, is it the wife, is it the father, or so. So in the biometrics, one of the things that is stamping out that those lives that were there is having the biometric. Now, in addition, again, I think it goes to the issue of ethics, in that I think about sincerity and honesty. If you are charged more drugs that you did not get, I think the issue is the facility, not NHIF. But NHIF is also putting systems in terms of thorough vetting of claims, where you need to go and even verify and even call the patient and know whether this service was offered or you got these drugs. So we are putting a very strong claim vetting system in place that is ensuring that it's curbing this malpractice.
Okay, so health is devolved right now, but should we have a central data system whereby if I walk into any facility and you type in my name, you should be able to find my medical history? Why is it that every single time I walk to one facility, they have to do all the tests from the top? I have to be registered. Have you registered? Do you have a card? Do you draw blood, test this and that? Even if I was just tested the first time in Nairobi, now I'm in Kisumu, they're doing the same thing. Why don't we have a data system where you type my name and see everything, my medical history, and you know where to start from?
Trevor, that is a thing of the past. With the new NHIF reforms and even the biometrics and the new digital health platform at the Ministry of Health and the Kenya Health Information System, we have decided to merge all that, such that even you appear in Mombasa and you are from Laikipia, you type in, we can be able to tell. This is Joseph Lenai, and the last time we were seen in the facility was in this facility. And apart from that, he is registered in NHIF in this facility. So we are able to do that with merging the Ministry of Health, Kenya Health Information System, with our digital platform, riding on what you were saying, the fiber optic, which is everywhere now. And apart from that, the biometrics that we have brought for NHIF.
So this is
so that is a thing of the past. With the new UHC strategy that we are putting in place, that is now in place.
It's not fully rolled out, is it?
Yeah, not complete, not 100%, but we are somewhere, Trevor.
What percentage would you give?
With the biometrics, we have finished entrenching into the KHIS and merging them. But in terms of looking at the issue of rolling it in all facilities, of course not, most dispensaries don't have that. But maybe the level 4s and the level 5s and the level 6.
So it's working
But the dispensaries, health centers, not yet. But we are headed there.
Okay. Professor Mugenda, I see you smiling there. There's a question directly for you. Milan Joseph on Twitter says, I'm a cancer patient undergoing chemotherapy at Kenyatta Hospital. What is the government doing to solve the issue of drugs? In most cases, we have never found all drugs at the hospital. We're always being sent out to buy 2 drugs every time we go for chemo. So this is not so much used Kenyatta Hospital, but how do we deal with this issue of having drugs that are not there? What is the best way of dealing with it?
I think maybe the ministry can answer that better because of KEMSA it's a bit centralized. Maybe Dr. you can answer that.
Trevor, I think, as I said, we have come from somewhere. Earlier on, there is what we used to call the essential medical kitty. That is being supplied to. There is that for level 6, there is that for level 5, there is that for health centers and so. Now, what we are doing is, now with the specializations like cancer, of course that changes. What we used to give level 6, and this is a cancer center, what we are looking at is, in the NHIF reforms, we are also looking at the issues of what package is going there, which is targeted, and looking at that. In the KEMSA reforms.
Prof, we're talking about quality. Yes, go ahead.
I was going to, Trevor, with your permission, go back to a bit of issue with early diagnosis. Because what we are finding is 70% of Kenyans will die eventually once they get cancer, as opposed to like 30% in UK or US.
70%?
So we try to find out what is the issue. And the issue is early diagnosis. if you go to the US and UK, it is mandatory for the annual checkups.
Yeah.
And you can't believe the number of people who are found to have the disease when they're not feeling pain. So you go for annual checkup, maybe 10% of the people have an issue they didn't know. So if, in terms of prevention, if we can start there, and I don't know whether NHIF can even cover that.
Yeah.
And then we encourage Kenyans to go for early screening, so that then the disease is seen in stage 1 or 2, or with IMIC is even seen before at the molecular level, because then the chances of getting cured are high, and then it's cheaper. So I wanted to emphasize that, because I think a lot of us don't go for screening. We don't go for checking. We just wait until we are feeling the pain, and then it's too late. And now that, Trevor, for me, I'm in the hospital system, and I can see those statistics every day. Almost everybody who is coming, we are finding they're in stage 3 or stage 4. And you can imagine then it's very expensive. And then, of course, the outcomes are not as good. So if you can focus on early diagnosis, screening, that will, as a country, that will be very good. But coming back to quality, I think it's a question of quality of doctors and the nurses. Are we training them? Yeah. Capacity building, programs like observership. We are doing that with Manchester, where we are going to be sending our doctors, even if for 6 months, to just see what happens, maybe have a bit of experience there. They come back and be trainers of trainers, so that even though they are trained and they are very good doctors, still additional capacity building is very good and for quality. And not just doctors, but also the nurses. But still, on the issue of quality is equipment. Yeah. And the other professionals. There are so many cases, Trevor, where patients are being misdiagnosed. Yeah. So that you have cancer, but you are told you have no cancer, or maybe you have no cancer, but you are told you have cancer. Yeah. So I think it's training for the other professionals who are interpreting these results, and making sure that we are getting the right the right diagnosis. Yeah. So quality of the doctors, quality of the other professionals, equipment that we are using. And I'm happy, as I said earlier, now that we have equipment that can show cancer very, very, very early, and then you can now be treated. Yeah. Okay.
Prof. Graham, there's an issue here. When COVID-19 came, the health care systems were exposed across the globe. It was not just here in Kenya. How do you build a resilient health system?
How do you build a resilient health system? Well, I think the response to COVID across different health systems was very informative. And obviously I speak from the experience that we had in the UK. And we were having actually discussions just last night about looking at comparing the response of Kenya to the UK. I think what we learnt from the UK is that COVID exposed the areas of pre-existing health inequalities across the system and widened them. I think what it also did was it showed if you like, the resilience or the lack of pre-existing investment in the UK, which is now causing problems in terms of a backlog of treatment. So I think there's two questions there. Your question of how do you build a resilient healthcare system, which is if you like, a sort of a theoretical question, and how do our healthcare systems now recover and build back after COVID? Because actually there's quite a significant amount of, if you like, damage to the resilience of our system, and I'm talking about the UK here, I won't talk about the Kenyan system, about how we recover from that. And part of that is investment in infrastructure, and by which I mean the machines and the hospitals, but actually the people. And this is about supporting our people having sufficient healthcare workforce. So there's an issue of quantity as well as quality, and Professor Magenda has already spoken about that quality to get it to international standards. And I think we need, in terms of the quality issue, quantity issue, we need more doctors and healthcare professionals for resilience, because people are overworked, and we know this is the reason that through the Kenya UK Health Alliance we're setting up the Centre of Healthcare Education and Training, which is with the hub in Kisii, but actually a spoke out to the rest of the country. So we're trying to address that about how we want our doctors and nurses to be trained, how many we need, and in what specialty areas. As well as the rise in non-communicable diseases across the globe, the World Health Organization has said that by 2030, we're going to have at current rates, we'll have a gap of 80% in our healthcare workforce across the globe. and the majority of that will be in sort of low and middle income countries. This is a real issue that's not going to go away if we keep doing the same thing. So how we train our workforce, how we invest in our workforce is, I think, the fundamental pillar of resilience.
Okay. And Professor Kibwana, let me bring you in on this as we wind up on this conversation. Is the solution building a facility almost like the KU Teaching and Referring and Research Hospital in all counties?
I think the institutions that are at the Kenyatta University level, of course you can do a lot of those, particularly in the short term, but still it is possible, like the example I gave of the First Ladies Initiative, with the County First Ladies Initiative, with several development partners. When it is...
Okay, we seem to be having a technical hitch there with Professor Kibwana. We'll get back to him in just a bit. But Dr. Lenai, let me come to you now. So what are the solutions from here? Where do we go from here? Because there's a lot of questions in terms of what are the solutions?
Thank you, Trevor. One, I think we still look at the three tenets of UHC.
Yeah.
One being quality, the other one access, and the other one is financial protection. Now, there are deliberate things that have been done already. I think long gone are the times now when we used to hear that when you go to Kenyatta or even Moi Teaching and Referral Hospital, you have to be booked and wait for 6 months. Now, with the coming in of KUTRH and even the hubs and spokes that we are also developing in Kisumu, in Kakamega, and also in Nakuru, that is going to be a thing of the past. Now, we already have an alternative.
Yeah.
We have just made Othaya an annex of Kenyatta National Hospital. And all services and specialists are also having time to go to see patients in Othaya. Now, equally also, Kenyatta University Teaching and Referral Hospital is babysitting Garissa, is babysitting Mombasa that we just launched the other day, the radiotherapy. Now, apart from that, what you are seeing is that the president also declared during Mashujaa Day that we are going to address again the issue of access by establishing 50 level 3 facilities, the primary healthcare facilities, countrywide. And what you find is that these facilities are being established in places where there is a higher population, but there is no facility, or where there is a facility like a level 4 or level 5, but it needs to be decongested. So that is the direction we are going into. But what is the future? We want to invest more in the primary health care. We want to invest more in the community health volunteers. We want to invest more in prevention, in early detection. And how are we doing that? Side by side with the UHC that the president launched, there was the primary health care booklet, our strategy that was there. The Cuban, the doctors we sent to Cuba, the family physicians from the counties are already back in the country. And these doctors were actually from each county. And what will happen is that these family doctors will be working with health workers at level 4, health centers, dispensary, up to the community level. Because they are trained on family medicine, they will be able to help on that aspect of preventive and also early detection and even promotive. And that is the direction we are taking.
Okay. Let me bring back Professor Kibwana, who is back with us online. Prof, you were finishing your thoughts before we lost you.
Yes, I was saying in terms of like the cancer issue, in many of these counties, working with the partners that I mentioned and with the assistance of Professor Chite, and this is essentially a First Ladies initiative at the county level plus the counties. We are developing all those cancer centers which give primary assistance to people who are suffering from cancer. And I think if we have that in all the counties in the first instance, And I think Joseph did mention some of the places where that is happening, including Makueni, Meru, Taita Taveta, Kakamega, and so on. I think that's a very, very important network. And then you can have at the higher level now specialist institutions like Professor Mugenda's institution, which has even international reach. But this question of also having level, and this is something that in the Baba Care has been emphasized for the future, having level 5 hospitals in every county, because that is also something that is not happened yet. That would also, the annual checkup, even at the dispensary level for blood sugar, for high blood pressure and so on, even at that low level, that would really assist a lot. And if the national level and the counties can work towards that, that helps a lot in terms of early detection of some of the non-communicable diseases. But I want also to emphasize the point of primary health. Actually, universal healthcare can only sit on the foundation of a robust primary healthcare system where you have the CHBs, the volunteers, and then this one have to be, you have to take care of them, because now you can't just volunteer and use your own money for transport and so on and so forth. And the promotion of a culture of wellness. And I think a professor from UK did mention that, that you have to have that so that people, you don't have obesity, people, they exercise, people do all those things. These are integral parts of a universal healthcare, robust universal healthcare program.
Okay. Professor Mugenda, what do you think are the gaps that are left in your closing remarks? So where do we go from here?
Thank you, Trevor. I think 4 issues that I've picked, and the first one is the question of referral hospitals in counties. And I don't know whether you have realized there are so many referrals in terms of names. But when you go there, they are not quite referrals. If you can make them truly referrals, because for example, ours, we are seeing a lot of people from Meru, even from Western Kisumu, they are coming. If we could maybe make sure that these are truly referrals, so counties have those referrals. And I think the governors, as he has said, they can make that happen. So that is one strategy. The other one, Trevor, is NHIF. We need to make sure that and I think Dr. here said it, we need to make sure that it's accessible to everybody. And I think there's one county, I don't know whether it is Governor's County, where they were actually paying for people who can't pay. Because we see it practically when somebody comes, they have NHIF, they come and they are treated and they go. Others come, they can't pay because they didn't have NHIF. So you can make it compulsory, and those who can't pay, we help them to pay. I think that will really, make it accessible. The third thing is, I think we need like a national campaign on screening. Because, Trevor, until you are now where we are seeing these patients every day, and then you wish, and some of them are people we know, they even themselves say, I wish I knew. So I think we need a national program for screening, but also our doctors. They also need to send the patient, and you said it right, until your doctor tells you, go and see, go to the PEP scan, go and see, you just go. You won't go. So I think the doctors need to also to send the patients early. There are so many patients who have, some of them we know them, they have died, and they're saying, but I've been having this problem for 2 years. My doctor never sent me for checking. So I think we need to have a campaign where our doctors are sending the patients early for testing. The patients themselves are going early for screening. Then we can deal with the cancer. And lastly, Trevor, is the question of the training and the capacity building. Again, we need a national program of training specialists. There are so few. Even in a hospital like ours, we are struggling to get those specialists because we have to share them with other hospitals. So can we have a long-term program, short-term and long-term program of training specialists, where the counties, the government decide in the next 5 years we need to have 100 oncologists, 100 specialists, and we actually go for it and do it. I think we need to have a plan, and I'm sure ministry, hopefully they have that in mind.
All right. Professor Graham, closing remarks, and also on the partnership that you're having with the KU and KC, what is the picture of success for you? What are you looking to achieve at the end of it all?
The Kenya UK Health Alliance is really focusing on two major areas at this stage, but we'll expand out to others. So the first one is around getting cancer care up to the best global standards for everyone in Kenya. We're working around the hub and spoke model. So actually the hub is at Kenyatta University Teaching Research Referral Hospital, but actually wherever you are in the country, you get access to the best care, whether that's around prevention, early detection, or whether it's around referral into a national centre for treatment that can only be offered there. That would look like success, and that we would see, and a simple metric of success, whatever cancer you're looking at, whether it's throat cancer, breast cancer, lung cancer, that actually the percentage of patients that are diagnosed at an earlier stage, and therefore we know it's curative, goes up, and the number of patients that are presenting at a later stage goes down. That's very, very straightforward to measure over the next 5 to 10 years, and that's how we measure it in the UK. And it's very difficult. If you can move that number, that's a profound change. The second thing, as Professor Magenda said, is training a new type of workforce that understands prevention, promotion of health and early detection. Part of that may be around a national screening programme, and I think we need to upskill, and I'm talking for the UK as much as I'm talking from Kenya. I think actually in many ways we have a lot to learn from Kenya about your data infrastructure, but we need to train our workforce to work within and with that data infrastructure. We're not training, and again this is in the UK as well, as part of our curriculum reform for medics, pharmacists and nurses, how do we embed that in the curriculum so that actually we're training the workforce that we want in 10 years' time rather than the workforce we wanted 10 years ago. I think those early steps through the Alliance are working really well to do that, and I think the benefits will be seen in that space very quickly. But actually what the critical point is, the long-term success of this is a sustainable healthcare system where you have equal access for every citizen of Kenya. Okay.
Let me bring up some of the feedback before we wind up on this. There might be some questions there. Let's bring them up on screen. And Trevor Mbija at Citizen TV Kenya is the hashtag Daybreak. Engineer Lazaro says health department still grappling in a lot of uncertainty, lack of drugs, lack of professionalism and goodwill to implement the so-called quality universal healthcare. Okay. Let's see what else you're saying. Governor 254 says major reforms should be education on health problems, development of proper nutrition, maternal and child health care, adequate and safe water supply, immunization against major infectious diseases, and local endemic diseases control. Okay? Let's see what else you're saying. Agumba Steve says, one thing I'm yet to understand is how it's going to be equitable under the NHIF scheme for those who cannot completely manage the monthly subscription at all. Quite a number of humble background Kenyans in the villages cannot access this, as priority is to those with. Okay? We'll get a quick answer from Lenai on that one. Mtuimara says, I believe healthcare is a civil right, just like education. It also needs to be given importance. The government has everything to gain when they prioritize human health. UHC is one of the most powerful social equalizers among all other policy options. All right. Dr. Lenai, on the issue, is there another one that you can squeeze in? Okay. W. Mukalavai says, this is a wonderful discussion. My prayer is that we're a national drive to test for cancer. This will help in early detection, management and treatment. Congratulations to NHIF for the new direction taken in covering your membership. I look forward to holistic national health cover. All right. Lenai, very briefly on the issue of people who cannot pay at all on NHIF. What happens? They cannot pay at all.
Yeah, and that is what the group that we are calling the indigent population, the poor of the poor. Now, we happen to dig back into the archives. You know, the national government has that data. The ones who usually get the monthly pay, the elderly, the orphans, they already have that data. Apart from that, we already have data which has been feeding into the Kenya National Bureau of Statistics. So we have been able to get hold of all those who are in the category of the poor, and those are the indigents that we are saying we are already paying 1 million of them. 1 million households, actually. Of course, each household can have like 5 people. Now, we want to escalate that. So those who cannot be able to pay, already in the NHIF, government has already given NHIF money, and that money is available for those people. When they go to any facility, it's just keyed in, and you are seen you are in the group of the indigent, you get the services.
All right. We have to leave it there, ladies and gentlemen. Professor Olive Mugenda, Chairperson, Kenyatta University Teaching, Referral and Research Hospital. Professor Kivutha Kibwana Makwini, Governor. Professor Graham Lord, Vice President, University of Manchester. And Dr. Joseph Lenai, Director, International Health Relations, Ministry of Health. Thank you so much for the wonderful discussion on the state of healthcare here in the country. I'm sure we'll have this discussion again at some point. And thank you for all the feedback that you sent through to us. We have to take a quick break now. Coming up is Willis Bazura Buru on Level Up. It's Friday, people. Bye for now.